Why skin diseases matter? Because skin diseases are common worldwide, can impair quality of life, may become life-threatening, psychological, and there is social impact. Now, there is some stigma associated with skin diseases like visible disfigurement, fear of contagion, social isolation, and it also reduces the self-esteem of the patient. Now, we discuss the epidemiology. Skin diseases affect all the age groups, and there are more than 2,000 skin disorders, widely clinical presentation. What is the clinical importance of skin assessment? Skin assessment is very important as it is essential physical examination component. It helps identifying the systematic diseases. It provides the diagnostic clues to other diseases. Now we have to follow a systematic approach, means we have to assess the skin in all the patients, we have to evaluate body systems in dermatology patients, we have to manage the integrated management system. Now what is the focus of dermatology? So number one, dermatology includes mainly focuses on common skin diseases, the systematic diseases manifestations, and diagnosis and the management principles. Now, there are few important infectious skin diseases like HIV related manifestations, tuberculosis, leprosy, and syphilis. Few high yield examples. Skin diseases affect the quality of life. It appears as a social stigma in some culture. There are more than 2,000 disorders. There is few systematic disease clues and the assessment is comprehensive. Now this is how we examine the skin diseases. Number one, first we check the distribution of rash, whether it is symmetrical or non-symmetrical, proximal or distal or facial, whether it is localized or whether it is widespread. Then we go for symmetry. Symmetry, whether it is on extensor surface or the flexure surface. Extensor surface, example psoriasis, flexure surface, example eczema. Then we check the involvement of hands, including nail folds and finger webs. Like as shown in this figure, there is involvement of nail. In psoriatic patient, there is changes in the nails and the periangular webs. Then we check for the involvement of axilla or the grains, like in hydrantitis suppurativa. Then we check the morphology of rash, whether it is monomorphic or polymorphic. Then we check the overall description of the individual lesion, whether the lesion is discrete or grouped or confluent or reticulate, means lace-like or linear pattern. Then we check the detailed morphology of the individual lesion using the magnifying lens in good light to assist the use correct terminology. For example, this is the morphology of palmoplantar pustulosis. Then we have to examine the scalp. There is hair loss associated with skin diseases. There are scalp changes as shown in this figure. Then we have to check for the involvement of face, whether there is involvement of central hairline, cheeks, nasal bridge. In around the cheeks and nasal bridge there is butterfly distribution, and in some diseases there is lesions behind the ears or under the skins. Then we check the eye involvement, like in cases of conjunctivitis or blepharitis. In rosacea or eyelash there is loss of alopecia areata. Then we check for oral and the genital involvement. For example, this is a skin mucosa of oral cavity. We see the reticulate or lacy network of buccal mucosa in lichen planus, and there may be some genital involvement also. Then we check the joint involvement, as in psoriatic arthritis. There is plaque psoriasis or the psoriatic nail dystrophy. Then we check for the general medical examination, including lymph nodes and other systematic systems. Now, it is very tempting to examine the skin first, but this is a mistake. First, we have to take a history, then examine the skin, and then list of the patient. So first take the history, including the onset and the course of the disease, the exacerbation or the relieving factors, the past history of the skin disease, atopy, autoimmune disorders, social history, occupation history, any psychological impact that affect the quality of life. Then we have to check the drug or the allergy history, like is whether the patient always take some drug or there is some allergy history. We have to check for all systematic and topical drugs and OTC preparations. Then we have to examine the skin. We have to examine skin, hair, nails, mucous membranes. Is it a rash or a lesion? Whether the distribution and morphology are important for a rash. We have to check all these while examining a skin of an individual. Then for closer inspection, use the magnifying glass or lens. We use dermatoscope sometime, which may be invaluable, and we have to check the size and detailed morphology of a lesion, which are the essential factor to elicit. Then we go for the general examination. General examination includes the peripheral lymph nodes that may be indicated or important, and some skin diseases may have systematic features like cardiovascular system involvement in psoriasis, and many systematic diseases have the dermatological features like diabetes. Now, there are different types of lesions, so we must use correct terminology, which helps in differential diagnosis and allow the colleagues to visualize the process. So number one, we have macule or a patch. It is a circumscribed flat area of the color changes which is less than or equal to 1 centimeter as shown in this figure in diameter, and it is known as patch if it is more than 1 centimeter. Then we have papule. These are papules, small discrete elevations less than or equal to 1 centimeter diameter. Then we have the nodule. Nodule is like papule, but it is quite deeper as shown in this figure. It is into the dermis or the subcutaneous layer, and it is more than 1 centimeter in diameter. Then we have the plaque. Plaque is a raised area of more than 1 centimeter diameter with flat top as shown in this figure. Then we have the vesicle. Vesicles are small fluid-filled blisters. These are small fluid-filled blisters which are less than 1 centimeter in diameter. Then we have the blisters or boa, which is large than 1 centimeter in diameter, and they are also fluid-filled blisters. So less than 1 centimeters are vesicles, and more than 1 centimeter diameter large fluid-filled blisters are the blisters or the boa. Then we have the pustule. Pustules are the visible accumulation of pus in the blisters as shown in this figure. Then we have the perichi or purpura. Perichi means the tiny macules due to extravascular blood in the dermis, and purpura are the larger and may be palpable also. Now, there is one score activity, which is a tool which is used for objective assessment of the disease severity. For example, in psoriasis, we use the psoriasis area and the severity index, which is known as PASI, which is a very important tool in assessing severity and the treatment response. So we have checked 4 body parts are each scored individually. To find the PSA score, first we check each of the 4 body parts like redness, thickness and scaling. Redness, erythema; thickness, that is the induration. Term for scaling is Discrimination. The score is between 0 to 4 and the area of each body part. If no body part is involved, then 0%. 1 for less than 10%, for 2 for 10 to 29%, 3 for 30 to 49%, 4 for 50 to 69%, 5 for 70 to 29%, and 6 for 90 to 100%. So when you check for 10%, these two 20%, this is 30%, and this comes to the 40%. So to find the PSA scores, add together sum of each part and the percentage of the part involved and the percentage weighting of that body part. Minimum score is 0 and maximum score is 72. So to conclude with, skin diseases are very common, they are clinically important and require comprehensive assessment.